I'd like to welcome everybody to today's webinar, where we're going to talk about the hospital reporting requirements for 2018. These rules come from the hospital inpatient and outpatient final rules. With that, I'm going to turn it over to my colleague and good friend, Miss Kathy Costello.
Thanks, Scott. Hello, everyone. So glad you could join us. We are, after having what seems like an inordinate wait to get the final rules. They are all finally released. We have the hospital inpatient and outpatient, the physician fee schedule, which includes ACO information, and also the new diabetes prevention program, and then the MIPS APM rule. So in case you just needed some light reading, they are all available and with this particular set of identifiers. One thing you will not see, and the reason I'm bringing it up, is a number of hospitals have contacted us about this, and that is the information blocking rules. As you recall, information blocking was an issue. It came out as part of the final rule over a year ago when it was being implemented for the first time in 2017. So I know a lot of hospitals are looking at their policies around information blocking and access to the portal and to information flowing from the provider to the portal. And I am here to tell you that we are still waiting for an updated rule on this area. CMS was supposed to have been releasing, actually in December, a rule on, updated rule on information blocking. And then they pushed it back to January. And since tomorrow's the 31st, I'm going to guess that typical CMS style that we probably won't see it until next month, and hopefully it will be out before HIMSS meets at the beginning of March.
I heard from HIMSS that it was going to be the second week of February that we'll see this rule. So we'll see if that holds true. Okay,
it's supposed to be a very short rule. You know us, we're looking at usually 2,000 and 3,000 page rules, and the information blocking one not only is supposed to be less than 100 pages, some are saying it's less than 50. That I'll have to hold my breath to believe that one. But when we get that, because it is an important area, especially for the hospitals, on your question of how you filter data that goes to the patient portal, we will schedule a webinar just on information blocking as soon as we see that. Okay, so one thing I put here is just the schedule that CMS puts out every year that lists the, not incentives, not like EHR incentive, but incentives as far as market basket payment adjustments, and then how they're affected by reporting or non-reporting for both hospital ACI. As you can see, they're still calling it meaningful user here, and the IQR, inpatient quality reporting. So in case you need information on that, this is straight out of the reg and should give you what you need. Let's start with the technical requirements. You lucky hospital people don't have to really live with as many balls in the air as on the ambulatory side. I used to think the hospitals were the one who were stressed over their reporting, but after we've been doing attestations on the physician side for the past several weeks, trust me, there's so many moving parts. So what I'd like to say, though, is you need to be aware of what's going on the physician side. Many of you are either integrated with your physician or your ambulatory provider reporting, or you're responsible in some way for it. So when we go through these questions, think in terms of both the hospital and the ambulatory provider areas. And what we recommend to every hospital to do is to sit down and draw up the workflow on the new areas of reporting and create a timeline for when you plan to adopt all this, because 2018, whether or not you're reporting stage 3 in 2018, you are going to have a ton of work around getting new workflow in place for stage 3 and for both the hospital and physician. And we'll go through each time on one of these slides where you're linked into a time issue on getting stuff reported or ready to report, we'll mention it to you. One thing that when you're doing your timeline, one of the first things I'd say is, what do you want to do for reporting in 2018? And we can tell you, we have yet to meet a hospital that has decided to report stage 3 this year. Even those who early on were thinking about it, most of them are staying with stage 2. The reason being that it's only a 90-day reporting period, and so many of you had run your 90-day reporting period at the end of 2017 for 2017 reporting. The measures are the same. You can run straight through the first quarter of 2018, have it done, get that report boxed up and on the shelf until the attestation process opens again, and then move ahead with your upgrades and workflow for stage 3. I mean, that's just us talking, but honestly, the feedback that we have is this is something that most vendors are expecting practices to do. I think a lot of, hospitals, a lot of hospitals don't yet have their complete workflow for stage 3, although the vendors have started to release more and more information on it. But there is going to be training that goes with that. So keep that in mind. And the other thing to have on your timeline, and this is specific to your own organization on what you're going to do, and that is, do you need to work into your timeline e-prescribing of controlled substances adoption, so EPCS. It is not required even under stage 3, but we know that many organizations on the hospital side had worked it into their overall adoption as they had to come up on ERX in the hospital setting. And many of them decided just to go ahead and do controlled substance e-prescribe at the same time or within a year. So if that is part of your timeline, make sure you put that on, because you will have physician education around that. And then the last question to put on your timeline is the adoption of appropriate use criteria. And Scott's going to go through that in pretty much detail as to what you need to get done before 2019, but you clearly need it on your radar and be building for it. It's going to require work on both your hospital and your ambulatory side. Once again, I'm sure many of you, this looks familiar, and that is because this is the same graph that we used in 2017, because the minimum reporting requirements in 2018 are the same. So you are still going to be looking at, on the ambulatory side, you're going to have your physicians either reporting for MIPS, reporting for APM reporting like an ACO or CPC Plus or whatever. So that continues on in very much the same vein as it did in 2017. Medicaid is physicians and nurse practitioners, PAs are still required to report to Medicaid if they have EHR incentive dollars to draw down. And for those of you who deal primarily on the hospital side, I know that's very confusing because they don't use the same metrics, but just be aware that you may be asked, if you're a report person on the hospital side working with the ambulatory practices, you may be asked for 2 separate sets of reports, because even though the measures look the same, they're not reported the same. So we'll look at that in a minute. But for the hospital side, you will have the 90-day reporting, as we mentioned, in 2018. This is another graph of it, and what I would want to point out to you is that this year, very important, it was stressed in the regs, and I know many groups commented on it and suggested that CMS not require hospitals to go with 2015 edition cert for a reporting requirement in 2018. but rather to allow hospitals to use either their 2014 edition, which is stage 2, or 2015 edition certification, and then be allowed the flexibility to select which set of metrics they want to go with. And fortunately, in the final rule, CMS did agree to this. And so the hospitals, that's really what allows you to do that flow through and to report the first 3 quarters of this year. I'm sorry, the first 3 months of this year, if you want to just do stage 2, and why it will look exactly like last year. What we don't know, and the reason we have a question mark on 2019, is even although CMS in the physician-facing rules, the ambulatory MIPS and physician fee schedule rules have already rolled back the reporting period on the physician side in 2019 to 90 days. They were very silent on the question of hospital reporting and whether or not the hospital is also going to have a 90-day reporting period next year. And the significance of this is, as you can imagine, is when do you have to have your stage 3 implementation in place? Clearly you're going to be working on it for this year, but whether or not it has to be up and ready to go by January 1st, or whether you're going to have a later adoption point in 2019 or reporting period in 2019. I would say at this point in time, because of the pushing back of the deadlines, that most of the vendors now, especially on the hospital side, seem to be ready to move on with stage 3. So it's really just getting the workflow in place. But recognize this is an issue, and the next set of regs for the hospitals will come out they usually come out in April or May, and that should give us some indication of what your timeline reporting in 2019 will be. But for this year, you will still be at 90 days. As I said, it's important to note that not just the hospital, but on the physician or ambulatory side, that you have that same flexibility, whether to do 2014 or 2015 edition cert. Very important for those of you who are technical, because you want to make sure that you understand what the need is in your ambulatory practices to have their systems up and have those appropriate upgrades in place. Although you do not have to report stage 3 this year, as we just mentioned, you can do exactly what you did last year. We think it's probably a good thing to review this for you, because you are going to have to be working with this all year to get all your workflows in place. So one of the big changes, and should not create enormous problems with the hospitals, but still one you want to be aware of, is e-prescribing in 2017, which was the year that the hospitals had to adopt e-prescribe. It was 10%. So last year was 10%. When it will continue to be 10% if you report stage 2 in 2018. But when you move ahead to stage 3, it does increase to 25%. So again, that's just something to look at. I know some of you have a rolling adoption going on where you may have started with your hospitalist, you may have started with your ED, but you may not have it across the whole facility or organization. So that is something you just want to keep in mind, is you're going to be looking at increased utilization of the ERX functionality. Besides that, there are not a lot of changes other than the new measures, and Scott's going to go through that in just a minute. The areas look similar. You obviously know view, download, and transmit, thank goodness, has stayed at 1 patient. Although most hospitals do not have a problem with this now. The patients have really started using the patient portals at a figure that, back in 2014, we didn't think we'd ever see. A lot of hospitals are consistently over 10% with their patient portals, and some are over 20%. The summary of care electronically is still at 10%. And your public health reporting, this is for stage 3, is still at 3. That had been a rollback from what CMS originally proposed, to have the hospitals report for public health or data registry reporting. But it is at 3. It's at 3 for 2018, whether you're doing stage 2 or stage 3. And it will be at 3 measures, whether you're, when you do stage 3 in 2019. So just keep that in mind, though. You're going to want to, the larger hospitals will meet that with immunization, syndromic, and electronic lab reporting. The smaller CH hospitals may want to be looking at registry reporting for 2019 for that third, what they've been taking as an exclusion. So with that, I'm going to turn it over to Scott to talk about some of this newer functionality that you're going to have to be working with in 2018 to get ready for 2019.
I'm going to go back a slide real quick. Yes, most of the new measures are pretty cut and dry. Let's look at that health information exchange, for example. You're already doing the summary of care, sending out the information. The number 2 there, the request accept patient record, that's, are you querying a source? Did you receive a CCDA or did you query the CliniSync HIE? And that clinical information reconciliation, again, cut and dry, it's an expanded med rec, really to include problems and allergies and whatnot. But the one that we feel is kind of loosely defined is the Health Data Incorporated. It's also called patient-generated health data or non-clinical data that you'll see in the reg, which is truly a misnomer, but it has several different names. But what they're asking for or requiring for here is really broad. It's pretty much any information or data that's collected outside of an encounter or stay, and it can include social service data, data or information that's provided by the patient or the patient's authorized representative, again, outside of the encounter. So let's say the patient goes home and then they send in their, their advanced directives, or they send their advanced directives before an encounter or stay. That's also counted. You can also include medical device data, home health monitoring data, fitness data, think Fitbit data. So it's really broadly defined. Again, let's talk about some of the other data sources. What you're seeing here is you're really looking at some data that is data that's structured. It can different documents. It can be a CCDA. But think about patients you send home with a heart monitor. That data can be collected. If you have a patient who has heart failure that's monitoring their weight, if you have a device like a Bluetooth enabled scale, that information can be sent over to the EHR, that counts. Patient reported outcomes count. Pretty much any data you collect that's not billing or payment data will satisfy this measure. It also can include patient data that's entered through the patient portal.
Yeah, and one thing I'd say about this coordination of care, because there's a whole category back on that stage 3. Yeah, you see how that number 4, coordination of care through patient engagement, is really something you want to look at in relation to how you set up your care coordination project or work for the hospital. You know, whether you monitor the patient, whether you have another group monitor the patient, you still are going to want to make sure that they have this information and that they are sending out the messages for secure messaging. So care coordination becomes more of an issue for the hospitals, even though the physician practices have been dealing with this now for a couple of years with their new alternative payment models. And this also, you can kind of think of this measure being somewhat linked to that API functionality that's now required for your patient portal. Think about a condition-specific application you have. Let's say you have some diabetic patients that you have under care management, you want to monitor their glucose levels. Well, you can give them a device where they take their blood glucose, and that information uploads through the portal or
goes through the API to attach to the patient record, that counts. So there's really a lot of different data sources that are included. Also included are what CMS calls data from the non-clinical setting. Such a misnomer. What they truly mean here is, think of your hospital outpatient services, nutritionists, physical therapists, your psychologist, behavioral health, all of those other outpatient services, their notes, their interaction with the patient really counts for this same measure. So it's just really very, very broadly defined. So, sorry, I'm looking at the wrong page of notes here. So again, this data can be stored as structural data or structured reportable data. It can be a document, it can be a CCDA. It can be stored within the primary patient record, or within that primary patient record, there can be a link to a secondary record or a file store where this information or documentation does then exist. And that secondary link, think of it as a way to keep that primary record from getting cluttered with all of this patient-generated or non-clinical data. And truly, this measure depends on how your EHR vendor implements the functionality. So reach out to them now, say, your guys are thinking forward about how you're going to handle care management, how you're going to handle data from devices that maybe now you're scanning in, but reach out to them now, find out how they are going to set up this workflow and what kind of documents can be counted towards. And again, it's so broad that it is going to be very dependent on your EHR vendor. So now we're going to set aside meaningful use for a second. We're going to talk about appropriate use criteria for advanced diagnostic studies. Now, this first came up in 2016. It was actually, I think, mentioned in the 2015 rules, and then there's some definition in 2016, and each year they add a little bit more to it. But what is appropriate use criteria? Well, really, it's functionality that's intended to ensure that an imaging study selected is appropriate for the specific clinical data available for the patient for which that study is being ordered. This was, again, it was pretty much outlined in the proposed and final rules back in 2016. Then in 2017, they talked about the clinical decision support mechanisms. And then in 2018, they talked more about how it's going to show up on a claims form, when it's required, when it's optional. And also in 2018, they punted. If you think back, last year, we were running under the assumption that we had to have this in place by 2018. CMS punted it down the road another year to 2019 because vendors were having problems. Folks were just having, it was too much this year to get ready for stage 3 and appropriate use criteria. So if you already have it in place for the 2018 calendar year, for your provider, on your provider side reporting, you can use it as an improvement activity, and it's one of those improvement activities that gives you extra credit towards your ACI measure. So use it now, get this functionality in place, get your providers used to the workflows, and get it tested to ensure that everything's flowing through to your claim forms appropriately. Now, the CDS rules do have some exceptions, or I'm sorry, the appropriate use criteria in the ED and the inpatient setting, and then there is a hardship for 1 year for the provider side, is where you can get an exclusion for the use of appropriate use criteria. So let's dig into this a little bit more. What does this really mean? Well, it means when you order an advanced diagnostic study, it is going to collect some information around that patient. Think about their problems, their the procedures they've had, and we'll take that information, run it through some criteria that are defined by provider-led entities that will then present to the ordering provider whether or not the CDS mechanism determines if that order is appropriate for the information available. Now, it also will display some supporting documentation. It'll show you the full criteria. It'll give you some links to other key evidence, and it's really the intent is to make sure you're not ordering something that just flat out isn't appropriate, or maybe you clicked on the wrong thing. Now, if the study comes back or the AUC comes back and says, hey, we don't think this is appropriate, you can still order that, and that is not grounds for a claim denial, though you would want to document why you moved forward with that order when the CDSM determined it as not appropriate. The original intent was for this functionality to be built or connected with the EHR, because the EHR is where all of that information that's necessary to drive the AUC is available. Now, it can exist outside of the EHR, let's say in a portal or a secondary application, but it is going to require that the ordering provider re-enter some of that information about the patient, you know, the problems and whatnot. So you're going to really be more efficient if this functionality is built right into your EHR. And quite honestly, most EHR vendors are building this themselves or working with a third party so that it is fully integrated. Now, the appropriate use criteria CDSM must be developed by a qualified vendor. CMS has what's required defined within the final 2018 rule, along with a list of those appropriate vendors. You can find that list on the the CMS website. They're focusing on 9 major areas for this first year of the appropriate use criteria. And over time, they're going to be adding more. But what we're really looking at here is the high dollar advanced diagnostic studies. You know, low back pain's a big one. But really, again, they want to just make sure that the high dollar study you're ordering and that Medicare is paying for is appropriate for the information available within your EHR. So that's really what's required. Again, it's optional for 2018. Get it in place. In 2019, for the ordering provider, it is required. For the performing provider, it's also required in 2019. There's kind of a grace period for the claims. They want to make sure that the claims have the appropriate use criteria identification number that shows that the ordering provider ran it. They want to see that on the claim form. It's kind of optional for a while. They're giving you a little bit of grace period on that performing side to make sure that you have your billing set up appropriately and that they're falling through to your to the claims out to the payer. So just get it in place now, work on it, and you got the beginning of 2019 to smooth out what rough edges are left.
Yeah.
So
we all know it'll be totally smooth.
Yeah.
We don't have any bumps at all. Thank goodness for the vendors. While they're working on that, at the same time they're doing stage 3.
Yeah.
So anyway, just generally, the 2018 requirements for IQR program, inpatient quality reporting, will be the same as it was in 2017. So you will be reporting 4 ECQMs for 1 quarter of your choosing. Let's look at other changes in reporting, and starting with HCAHPS. And it's interesting because a number of the changes that are being driven by in the hospital reporting area really are driven by the opioid problems and the whole epidemic and how it's affecting hospitals. So it's been interesting to see, looking at these new metrics with that in mind. You see it touching the hospital's reporting in several places. The first place was the HCAHPS survey, which, as you know, is a patient satisfaction survey. It's run for your inpatient patients, but also the separate CAHPS survey is done on the outpatient side. But on the inpatient side, there were specific metrics that has to do with reporting of pain levels by the patient. And here's what the current questions are. During this hospital stay, did you need medicine for pain? How often was your pain well controlled? And how often did the hospital staff do everything they could to help you with your pain? Well, when you read that, it's very subjective. And it's subjective to the point, does the patient feel that their pain is controlled? And what CMS was getting a lot of feedback from hospitals around this, because since it was so subjective, they were concerned that it was encouraging staff to go ahead and medicate the patient whenever they were asking for it, as opposed to using best clinical practices. And so it was something, since this is one of those publicly reporting measures through Hospital Compare, you just want to be aware of what you're asking and what the impact is. So after the hospitals raised this issue, and the American Hospital Association, quite a few individual hospitals raised it, CMS did a scramble. They actually did very quickly, and they didn't even wait for it to go through the normal review process with NQF and stuff. But they created a new set of survey questions for the HCAHPS survey around pain management. And rather than asking pain management, they asked a more objective pain education question. So those last 3 questions are now being replaced this year for these 3 questions. During this hospital stay, did you have pain? How often did the hospital staff talk to you about the amount of pain that you had? And how often did the hospital staff talk to you about how to treat your pain? So the hospital is not getting judged now on whether the patient subjectively feels that the pain is being controlled, but rather, is the patient being appropriately educated as to the cause of pain and the treatment of pain? So the idea is, and it'll be interesting to see how this translates into overall reporting for the hospitals, if this does help alleviate the need for feeling that you have to provide medication regardless of, the best practices. The second one is also linked to opiate use, although CMS didn't quite say that in the regs, but they talk specifically about it. And that is, it's the outpatient quality reporting, and it has to do with OP18. OP18 is the ED throughput measures, and the only one that is currently reported for hospitals on Hospital Compare and public sites is the ED throughput generally. How long does it take from the time a patient hits the door of the emergency department to when they're discharged or moved into the inpatient setting? So that's what has been the public metric for ED throughput. What CMS had proposed was to take one of the subcategories of reporting. You all report on it, it's just not reported publicly. And that is, in the case of behavioral health patients who are identified with some type of behavioral health need when they come to the emergency department, how long does it take for them to be discharged? And CMS does say that the behavioral health metric also includes as a subcategory the drug and alcohol cases that come in, opiate overdose, and anything in this area. And so when they originally proposed expanding the public reporting of this, I mean, as I said, the hospital's always been reporting it, but was it going to be made publicly available? And it was the law of unintended consequences, because I think CMS said what they were trying to do is to make sure that behavioral health cases were treated equally with other patients in the ED, in the sense that they were getting their issues resolved, problems looked at in a timely fashion. But the reality is, and when people commented in the regs, they said, look, we are good organizations. We are, have high quality, we take care of our patients and stuff. But the reality is, when you get a patient with behavioral health needs or drug and alcohol, it is a totally different referral pattern that goes on there, in a different skill set that's needed to address what is going on with this patient. Frequently, these patients are ones that are referred into the community for support, or may have to go to an inpatient bed, of which, as we all know, there just are not enough of them. And so the wait time can be significant in getting these patients actually taken care of, in the sense that they would then be discharged, in quotes, so that they would fall within this ED throughput measure. But the reality is, as a patient and not as a statistic, these patients need more care than can just be quantified by measuring the number of minutes that they're at the ED, especially if they come in the middle of the night and there's a referral that needs to go to a behavioral health center and that doesn't open until, you know, the morning, or as I said, that there may not be a bed or a provider available, and it may take several hours to get this referred to. So as a result of the feedback that CMS got on this, CMS decided that they are not going to publicly report this information. They, at least not on Hospital Compare. It will be reported on data.medicare.gov, which is like the huge database of all institutions across the country. But it doesn't go into that Hospital Compare, you know, how good are you in relation to the next hospital in your area type of thing. What does the patient see and stuff like that. This is more, it's being put onto the data.gov website to basically for research purposes. But so your reporting will continue to be the same, but just one should be aware as to what all the discussion was around that. I think two of the more substantive changes in quality reporting for this year is the stroke 30-day mortality rate measure, which you're all quite familiar with, is something that you have been reporting. But what goes into the metrics around that is what is changing. What CMS is seeing is that more and more hospitals are adopting the NIH stroke scale as part of their analysis of the patient's needs in the clinical situation. And that coupled with the move to ICD-10, where there was more specific information available as to what had brought the patient in the first time, so that it could then be looked at on the review, meant that CMS is trying to narrow down and take what's available as far as data and really dig down on what is causing these stroke cases, you know, to have 30-day mortality. And so they were trying to take this information and make it more user-friendly, shall we say, for clinicians. And they felt that by adoption of the NIH stroke scale, this again would focus better on the clinical conditions that actually go into that mortality figure. And the measure is supposed to change beginning in 2021, but it is on data collected starting July 1st of this year. It will be publicly reported in 2022. This next measure, and to me this is a key element, because all of you, every single hospital we've ever walked in is concerned about the hospital readmission. We know it's the #1 metric for both CMS, for Medicaid, for the private payers, the readmission rate. How often does the patient who came to see you and was discharged either from a procedure or for an illness, was discharged from the inpatient setting and showed up again within 30 days, either in your ED or in another hospital's emergency department or inpatient setting? And so this is one thing that CMS has made as a big priority this year, is working with hospitals to try to figure out through a combination of clinical and claims information, what it is that are good predictors of a patient coming back in within 30 days. And it's something, as I said, all of you are grappling with. I don't know a place that is not working on developing their database around this, whether it's through manual chart abstraction or a sophisticated program. We are seeing every hospital trying to figure out how this should work. And so what CMS is saying, here's what we think the information that as a clinician that you would want to know about so you could predict whether this patient needs more care before they're or after they're discharged, in a different setting. What is it? And so they had set up this pilot, and then this year is going to be a larger pilot. They're looking for, I think, 100 hospitals to participate in this. But the original few pilot hospitals, the providers liked seeing this hybrid measure because it gave them real-time data, unlike the old claims data, to try to help them in making decisions about how ill this patient is and what the appropriate disposition is as far as where they leave when they leave the inpatient setting. So here is, let me just say before we look at the measure, is where it is. CMS had wanted to make this mandatory starting in 2020 based upon the pilot this year, and then having hospitals start reporting next year. And they pulled back on that in the final reg, but they are going ahead with this 100 hospital pilot in which they're trying to gather the data and synthesize it more. And for those hospitals participating, they want at least 50% of their Medicare Part B patients who are being readmitted, and that report would be sent to CMS in the middle of 2018, and you would have to do what I'm going to assume is similar to an IQR report, third quarter of 2018. But if you're not part of that study, don't worry, that's voluntary, but you do want to be watching this metric because it's called the Hospital HWR measure, hospital-wide readmission measure. And here are the data elements that you would have to push to CMS to participate in this, or what you're going to have to be looking forward within the next 2 years as information that's going to have to be sent probably as QRDA level 1 file. So it's, as you can see, pretty standard information within your system, but you're just going to have to figure out about creating the reports around it, because it's pretty standardized lab work, nothing unusual with that. And then your blood pressure, respiratory rate, temperature, oxygen saturation, and you can see. So it's not unusual, it's just unusual to combine it in this type of reporting. The other side of the picture, the claims side, is CMS is going to pull this data in much closer to real time than they normally do, and look at the date of birth, the sex, and the admission discharge dates and obviously the diagnoses, to try to come up with this kind of formula as far as prediction of readmission. And they are going to assign to hospitals a risk standardized readmission rate. RSRR is going to be calculated for you. But as I mentioned, not mandatory this year, but something you definitely want to be working on. Another thing that I just want to point out to you, because we have discussed it a number of times, and that is actually on the physician reporting side, but because it affects hospital reporting, we felt you needed to be aware of it. There had been a proposal in this past year's regulations, 2017, to allow a physician to meet their quality reporting standards under MIPS or MACRA if they were a hospital-based physician, to basically piggyback on the hospital's value-based purchasing program quality submissions. So your providers would be included under that, and it would count for their physician reporting. Well, at the last minute, it was so funny because they were so detailed. They really had given this a lot of thought. Obviously, a lot of hospital-based physician groups had been talking to them about it. Yeah. And because, let's face it, of all the ambulatory providers that are hard to report for, it's the hospital-based, because they don't fit into the neat pigeonhole with so many of the ambulatory providers. And so it seemed like a good solution, but CMS was like, when the reg was finally finalized, like a month and a half ago, they're like,
Nope.
we felt a little, thought better of this. So we're going to wait on that until 2019. So that's a to be continued measure, is what's going to happen with what we call facility-based quality scoring. So you hospitals out there, just keep an eye on that, because I do think that this isn't permanently put to bed. I think it's something that will come back through, and that is something that would allow hospital and physician reporting to be more closely aligned in areas separate from ACO reporting. So with that, I think the last thing I'd say is be aware that the extraordinary circumstances exception is a change in kind of CMS's effort to combine a lot of the various like hardship and exceptions for reporting that are caused by things outside your control or things within your control that didn't go well, like an example that they have cited a number of times in the past set of regs is if a hospital goes to a new EHR system or a major new platform.
Or the EHR vendor loses their certification, which has happened.
Right, that CMS is looking more kindly on allowing you to get a hardship for, or they're calling it extraordinary circumstance, for that reporting that you can't do because it's somewhat out of your control, if not totally out of your control. And obviously, natural circumstances, natural disasters like the hurricanes this year automatically fall into that category.
Fires in California.
But the fire, right.
Yeah.
But there's so many other areas where you at the local level may have something going on with your vendor that prevents you from reporting. And so just be aware that CMS has kind of changed this to a rolling admission or a rolling submission for extraordinary circumstance exception. So as soon as you are sure that you're not going to be able to report, I would go ahead and try to get that filed. So with that, we put in a number of links here for you. These are things that CMS actually just put out in the past 2 days on information that we think that we find helpful to help you with your attestation, and then enrollment guides, everything we could find that would help you in working with CMS on your reporting. So with that, I'm going to turn it back over to Scott, and let's see where we are with questions.
All right. And if you guys do have issues with the attestation process, or you just want someone to virtually watch over your shoulder, let Kathy or I know. We can set up a GoToMeeting. We've helped out quite a few organizations get through the process. Again, it's not a difficult process, but it can be a bit intimidating, especially the first time you go through it. It looks like we do have some questions here. All right, first question. So can we report 2018 data with stage 2 requirements, even though we've already submitted with stage 2 for the 3 previous times?
Yes.
Absolutely.
Yeah, somebody has a long memory. Linda, I agree. Remember back when Meaningful Use started back in 2011? It was like you do your 2 years on stage 1, 2 years on stage 2, and then everything else is stage 3. And that was so confusing to people because that was out there for several years. And CMS backed off of that within almost a year. Definitely within 2 years. And so they actually had people have been sitting and performing at stage 2. Some people for this may be their 5th year at stage 2. So you're absolutely fine. So don't count the years. Look instead at what CMS has changed to the reporting guidance. So you can do stage 3, but you do not have to, even if you've done stage 2 3 or 4 times before.
Next question is, Meditech released some documentation that the AUC was going to be postponed again until 2020 with voluntary reporting in 2019 and mandatory reporting in 2020. Can you confirm this? Now, it's my belief that it becomes mandatory in 2019 with the information following the claims for a test period up to 2020. But Eva, I will confirm that and follow up with you. And if I do find that it was in fact punted, even to 2019, we'll let all attendees know.
Yeah, I would agree with Scott. What we're seeing is kind of what we call the soft landing here of the AUC, in the sense that CMS keeps like taking bites out of it. But when you look at the regs together, they really want it implemented by the beginning of 2019. But there's not a penalty phase that goes with that.
Yeah, and it's really focused in 2019 on the ordering side, because there's some question about when the ordering provider submits the appropriate use criteria, they get this little number back that says, more or less, it's an identifier to say, hey, I did it. Well, how does that number get over to the performing provider? They kind of left that out of the regs and realized it and said, we've got to work on the transmission of this.
Yeah, so it's the workflow issues that are still being kind of worked over here.
Okay, next question is, must patient-generated data be part of the clinical reconciliation? And here what we're seeing is a kind of a blending of two measures. The patient-generated data does not necessarily need to be part of clinical reconciliation. That's more for the receipt of a CCDA, whether it's from a direct message or if it's retrieved from an HIE. It's that clinical reconciliation.
Right.
And think of clinical reconciliation as expanded MedRec. It's problems, allergies, meds.
Yeah, Margaret, I definitely, always when you're going to have a patient encounter, I'd look to see what patient-generated data there is, but considering all the potential sources of it, PT report or something like that, you would want it all, but the actual clinical reconciliation really goes to the meds, allergies, problems, your core set of area or core set of
it's the discrete data that's available in that CCDA.
Right, really. Right. And then anything beyond that you feel that you need as part of your reconciliation.
Next question. For the AUC, should the vendor or organization take ownership of keeping the latest guidelines available in the product? Now, the way this works is the actual criteria are developed by what are called provider-led entities. And these are a group of radiologists and other specialists that kind of define what conditions, what problems are appropriate for an advanced diagnostic study. Then the vendor writes the functionality about how they're going to collect that data from your EHR, from the source, and then compare that against those criteria that were defined. In my mind, it would be up to the EHR vendor to ensure that they have the latest criteria loaded from the PLE, though some vendors may offload that to the organization and say, hey, here's the process that you go through to update that PLE information. So again, Margaret, it's going to be dependent on the vendor. And so I would definitely review the contract and the requirements around your AUC. Next question, this one's for you, Kathy. If we want to pilot the hybrid measure, do we need to let someone at CMS know, or do we just report it in the third quarter?
Eva, I believe you have to let them know, but we will look at that and find out, mainly because I think they're interested in having some idea of the size of the pilot pool. But let me find out if you can still participate, which I believe you can, and as long as you're willing to report information to them. But let's see if we can get a process, and we will answer that to everyone as part of the follow-up on this.
There's some question about slide 28, which is where you talked about the facility-based scoring, counting for a hospital-based provider under MIPS.
Right, Margaret, yes, you still have that whole scenario of how you handle hospital-based reporting for MIPS, and where they could be excluded from ACI, but you're still going to have to include them for quality and stuff like that.
Yeah, and it was always difficult under the old PQRS program. How do you select measures that are meaningful for your hospitalists, for your ED physicians, for your radiologists?
Right. But what they were trying to do here was to create a new mechanism to help these physicians for the quality reporting. Since so much, I mean, if you deal with hospital-based physicians, so much of their quality metrics is drawn out of the hospital system. And so I think it was just CMS's effort to make it easier to report quality for this group of physicians, but they, as we mentioned, they backed down off of this quote facility-based reporting, which was a piggybacking on the value-based purchasing program. So where that leaves you with your hospital-based physicians is still sitting in the MIPS program unless they're excluded as advanced APM providers, QPs. Otherwise, you're going to have to include them as part of your MIPS reporting, either as a group or individually. And if you're doing it individually, you may end up having to fall back on some of those quality metrics that come out of your hospital EHR system.
And, you know, if I were a bet man, I would say in the future, as CMS expands the number of measures that are required to be electronically reported under the hospital-based program, that we'll see that be included. Like if you, let's say you have some surgeons that are hospital-based. Well, if you selected some surgery-based measures under the IQR program, then maybe those will count. But again, that's down the road. We're probably going to see some more discussion this year and next year before we see a final rule on that.
Yeah, the proposed regs will really kind of give us an idea of where CMS is headed with this.
Again, I want to thank everybody for attending today's webinar. It has been recorded. We are going to get it uploaded to the CliniSync YouTube page here in the next couple days.
Thanks so much, and everyone have a great day. Talk to you soon.